everyone. So you'll recognise some familiar faces. So yeah, today we're going to think about autism and as a diagnosis in adulthood. So people who have had a diagnosis in adulthood, and we're going to try, oops, there we go, think about actually why now? Why now do people come forward for a diagnosis when they're an adult? A little bit about autism spectrum disorder and the new DSM criteria. What the NICE guidelines say about diagnostic procedures. The advantages and implications of having a diagnosis and how someone might adjust to their diagnosis as well. And also the types of support that are vital when you support someone with a diagnosis. And throughout, you'll hear me talking about the autism strategy. Does any of you know that actually the latest update was published yesterday? Yeah, so in terms of the autism strategy that obviously came out with, in conjunction with the Autism Act, now has been updated as from yesterday, and that basically details or gives recommendations to local service providers, local authorities about the type of services they should have in their local areas, and also the rights of some on the spectrum when they're an adult experiencing autism spectrum disorder. So it's there, it's a useful guide if you want to access it, and I'll briefly be touching on that, but if you'd like to know anything more, then we can also provide you with a reference as well. So autism is much more common than people think. It does affect 700,000 people in the UK. So roughly it's about 1 in 100 that we know about. You're right, it's a hidden disability. So you can always tell that someone has it. And that's particularly the population that we're going to be talking about today. And it is a neurological condition. So like we talked about yesterday, if you compare someone, a brain scan of someone with autism and without autism, there are very clear neurological differences. And that explains why someone might see and view the world differently than maybe someone who is neurotypical without autism. Okay, so it's a spectrum condition. So although some people share similar difficulties, the condition will affect them in very different ways. And I've never met anyone that is the same. Everyone is unique. Some people can have independent lives, where some people might need lifelong support, including those people with very high IQ and intelligence as well. That's often a myth around autism spectrum disorder. Now, the reason why I'm briefly mentioning these points is just for you to hold this in mind as you go along. So, people are probably familiar with Asperger's syndrome. So many of you know from our talks that we no longer give the diagnosis of Asperger's syndrome. So people who have a diagnosis of Asperger's syndrome, that's still viable, that's still an important diagnosis. But anyone who comes through the diagnostic procedures now will automatically be given an autism spectrum disorder diagnosis. And that's really because if you think of the spectrum, it's a wide spectrum here, but nearly everyone on the spectrum will whether they have IIQ or severe learning disabilities, will be affected by things like communication, social interaction, difficulties, maybe things with change, knowing what to expect, maybe have sensory difficulties. So wherever you are on the spectrum, you might have similar things in common. Now, the reason why there was changes to the DSM criteria is to eliminate that myth, really, because there's all sorts of myths around. So at one point, even things like financial and support opportunities, people with a diagnosis of Asperger's syndrome in some parts of the country couldn't access benefit entitlement, couldn't access support because merely of a label of Asperger's syndrome and the myth around that. So, just briefly about the DSM and what the new DSM criteria says. So, it's a little bit dry, so forgive me. The DSM is a diagnostic statistical manual. So, a psychologist and psychiatrist we use classification systems. Now the one that we use is the DSM-5, and that was updated last April. So anyone who had a diagnosis after last April will have had a diagnosis of an autism spectrum disorder. Anyone prior to that will have been using the old DSM criteria, DSM-4, and that would be Asperger's syndrome. It may have been obviously autism spectrum disorder, let me think, pervasive development disorder, all under the same kind of umbrella. But firstly, when we're a clinician, we have to think about the first one. So the person would have to have persistent difficulties in social communication and social interaction across contexts. So not just in one context, but over the different contexts. And it needs to be manifested in any of, well, all three of the following. So difficulties in social, emotional, reciprocity, I can never say that, get my mouth around it, but that's in terms of kind of things being reciprocal. Difficulties in non-verbal communicative behaviour, such as social interaction. So if you think of conversation, and when you're interacting with someone, it may be that if you think of non-verbal communication, we're thinking about facial expressions, body language, tone of voice, all those different kind of non-verbal sides of communication. And we know that lots of people on the spectrum not only struggle to interpret those non-verbal sides, but also as well, they may struggle as well in terms of adjusting their own facial expressions, knowing what to say, what to do, how to position themselves in different contexts. And also difficulties maybe developing and maintaining relationships and friendships over their lifespan. So we want to see that the person has difficulties in all three of these areas. Now the second part is the person will have difficulties with restrictive repetitive patterns of behaviour, interests and activities by two of the following. So we're looking, it might be someone may have stereotyped motor movements, they may have an excessive adherence to routine, or maybe ritualized patterns of behaviour, or maybe kind of difficulties with change. A person may have sensory difficulties, sensitivities, interests as well that might be heightened, or as well there may be almost like a fixated interest or hobby that might be quite intense in nature. So we're looking at two of the following of these. Now what we do need to find out is that these difficulties have been present over the person's lifespan. So what we think about when we diagnose someone with autism is the evidence behind a person's diagnosis. So if someone's diagnosis or someone's difficulties started at 20, what we know is that that might not be a neurological condition. There may be other things that might explain that person's difficulties. Anxiety, for example, OCD. Many people come forward who might have extreme anxiety or OCD. They're quite common when actually it may be actually their anxiety and experiences that explain their anxiety and OCD rather than actually being on the autistic spectrum. So we need to think about, and normally we think about probably from around 4 and 5 years old really upwards, we're wanting to find out the person's developmental history. We need to know that that person, it may limit or impair everyday functioning. So what we know often is that lots of people on the spectrum may struggle in everyday life, things like it may be within their job, or maybe within their relationships, friendships, maybe social isolation. But also that it's not explained by anything else. So like the anxiety and OCD scenario, that it's not explained from something that may be psychological in presentation, but also a learning disability as well. So we're always thinking about if there are other things that might be going on when we think about a diagnosis. So, receiving a diagnosis of ASD is a huge impact on the individual's life and those close to them. So actually, why now? It may be often the person may compensate for their intelligence. So if someone is very, very bright at school, then often the teacher might see their intelligence, and that actually may shadow their difficulties. And also as well, in terms of intelligence, often when you are intelligent, you can think of different ways of coping as well. Then maybe if you have a learning disability, it may be harder to think of the other ways of coping and masking your difficulties. It might not have been picked up in school because, again, if you think of many years ago, how we thought about autism, often we thought about it as a stereotypical version of autism, almost like Canada's autism, the learning disability version of autism. So, especially in the educational establishments, we were often thinking about autism in almost kind of that kind of framework. You're right, in terms of a well-supported support system, it could be, I've worked with one particular individual recently whose mum did absolutely everything for that person, to the point then that, and she just naturally, because she was attuned to her child's needs, you know, she didn't even question it. You know, so she would regularly help him with planning and organisation, and always on the phone to him, prompting him because of his memory difficulties, she would encourage her other son, his brother, to engage him in his friendship circles. So all this kind of scaffolding that was around, so to the outside person, actually he looked like he was functioning very well. But actually when that was removed, often when, especially when someone goes to university, often if you think of someone's support system, that's when more social demands are placed on someone. You might start to see actually more autism specific characteristics of behaviour. And you're right, there may be a confusion with something else that's going on. Because actually the people with autism can also be prone to all sorts of other things. There's a talk on tomorrow about autism and mental health. Because mental health difficulties, it's really common for someone with autism to have also other things that they might experience. But if the clinician who is working with the person and who is diagnosing the person is not familiar with autism, then they may think through a mental health eye rather than an autism eye. And also there's a huge empathy debate. We touched on this yesterday in one of the talks, but I've worked with many women actually who have said, no, it was questioned if I had autism, but they said I had empathy, so I didn't meet the criteria. When actually what we know is empathy is much more detailed than what we think. There's many characteristics of empathy. So again, Simon Baron-Cohen is revising his theory on empathy. Probably the population that we're talking about today is probably moderately functioning. So it may be that the people close to them know about these difficulties, and they know that they might have difficulties meeting and maintaining friendships and relationships. They may often isolate themselves and find social interactions difficult. They may have difficulties sustaining employment, and may have reoccurring health difficulties. So they might actually be known to mental health services, and might have been known to mental health services for a long time. Now, also why now is we actually know more about autism now. So we're more aware. So things like events like World Autism Week are designed to raise the awareness of autism. So as clinicians, professionals, individuals, carers, family members, we're all thinking about autism, and we're thinking about the people who we love or support. So we now are more aware that autism just doesn't affect people with a learning disability. It can affect people who haven't got a learning disability as well. Now, often we have found, especially in the past, that people might not have come forward for a diagnosis because of stigma, because society thinks that people with autism may respond in a certain way. And often I've met people on the autistic spectrum who say, I don't want a diagnosis because society will think X, Y, and Z. So that might limit people coming forward for a diagnosis. But again, because we're now raising awareness of autism, hopefully that stigma will break down. Now, Howlin and Ashgarian said that many people might have experienced long waits for a diagnosis due to presentation of very subtle traits. So especially women, and I'll go on to women as well, women are much harder to diagnose than males on the spectrum. Now, again, it's also hard as an adult to entangle. If someone has social communication difficulties, it's hard to entangle where did that come from? Because what we know as well is often when you are on the spectrum, actually going through the school process and the educational process is traumatic in itself, and it's going to create fear, it's going to create anxiety, it's going to create all sorts of problems as well, and also your vulnerability to things like bullying also is increased. So, coming on to females with autism, now there's lots of potential theories of why females are harder to diagnose. Now, if you look at the statistics often say that people who are males are more prone to autism than females, yeah? Yeah? Now, I think there's maybe a possibility, but I think that actually it's harder to diagnose women. That's why the statistics are not reliable. Now, because of the male gender bias, girls are often missed. So we're much more likely to see females in mental health services on the spectrum because often clinicians are not thinking about that autism actually might be apparent, because actually no, that's something that males have. And females, if you think of a female growing up, females become masters at mimicking and just copying their peer group, because from a small child, a girl has to interact with another girl. They have to think about girls are always generally more chatty, aren't they? If you think of kind of a group of small girls and a group of small boys, the small boys go off and play football, don't they? You know, they go off and play sport, and whereas girls they're very much about with their dolls. They're very much about kind of almost kind of acting out scenarios. So girls much quicker get to actually almost kind of learn ways of coping. But actually that's why often females do end up with much more severe anxiety and depression, also because of that. Because of the amount of energy it must take to mask being on the spectrum is absolutely exhausting. So we talked about that yesterday, didn't we, about kind of, if we think of social interaction, and we think of the layers of what social interaction involves. So you have to kind of look at someone, you have to position yourself, you have to make sure your body language is not kind of offensive, and you have to kind of turn to them, you have to listen, you have to turn take, ask for reciprocal, you have to be interested. There's all those different layers of social interaction that often someone who is neurotypical almost kind of takes for kind of granted. But that's why it can be so exhausting. So if it's so exhausting, then you know that's probably going to make you feel pretty frustrated, isn't it? Pretty low, and kind of pretty hopeless really at times. So that's why often people with autism can experience really high and really common for someone to experience anxiety and depression. And we will go into more about that tomorrow if you're interested in that talk. And again, you know, it possibly might explain that in the high statistics of women with ASD with mental health problems, but actually I'm meeting more and more and more men on the spectrum who also have lots of difficulties with mental health as well. But again, that's a separate debate around gender and men coming forward for psychological therapy on all the bias around kind of gender and stereotypes around therapy. So, how do adults get referred for an ASD diagnosis? So this is often, we normally get lots of calls on a daily basis at the Tuke Centre saying, how do I get a diagnosis? So, you know, where do I start? So we normally suggest to speak to your GP or speak to a medical professional who can make a referral. Now there's key bits of legislation that's important to use, and the National Autistic Society have got a really lovely page about kind of what to actually go and what to say to your GP and what sorts of legislation to talk about. But use the NICE guidelines, which is what I'll come on to and describe, because the NICE guidelines say that if you have difficulties in the following areas, which I'll explain, then you are entitled to a diagnosis. Now, use a new updated autism strategy as well, which talks about that every local authority must have access to an easily accessible service. And again, giving guidance about using the NICE guidelines about referrals. Because what we do know, especially in the York and North Yorkshire area, is that autism diagnosis in adulthood are being commissioned. So often it's about your GP being educated, and we often have conversations with GPs about their own awareness of autism, and also about helping with what to put on a funding application. And of course, you can pay privately, but it's important if you do pay privately for a diagnosis that the clinician uses the NICE tool, well, the tools that are recommended by NICE. So if you think of if you need a heart operation, or if you need any sort of health or therapy, you often, as a clinician, you would often consult the NICE, the National Institute of Clinical Excellence, because that's a particular framework and guideline for a clinician to say these are the types of tools that have the most evidence base. Yeah. Okay. And of course, autism has its own guideline. And this is the reference there if you need it. But this is why it's important to know about the NICE guideline, because it's there as well to be able to use when someone wants a diagnosis. So in terms of what it says around identification and assessment, it's always important for the clinician to consider whether this person has one of the following difficulties. So you can go to your GP and say, well, I know that NICE guidelines say this and this. I know that I have persistent difficulties in social interaction. Or I know that communication is a difficulty for me. Or I know that people have said to me that I struggle with change, or routine is important and I struggle to cope when my routine is changed. Or I might have restricted interest, which means often lots of other parts of my life will often be affected. Also as well, NICE guidelines talk about actually then saying maybe one of the more of the following. So if you've had trouble sustaining employment or education, if you've had difficulties initiating or sustaining social relationships, if you've had previous or current contact with mental health services, or if you've already got a history of a neurodevelopmental condition such as a learning disability, ADHD, or another mental health difficulty. So there's things there, so you could actually go to your GP and say, well, I'm having difficulties with social interaction and it's really impacting on my education or my employment. So you, under the NICE framework, you could take that information and say, I know that the NICE guidelines would then recommend me going for a diagnostic assessment. Now, what they do say in terms of NICE guidelines, it talks about screening. And we also think it's important at Tuke Centre, we offer screening appointments as well. Now, there's something as a GP, the GP can use the AQ10. We use the AQ, the longer AQ, at the Tuke Centre. So we use the AQ, the EQ, and the relative questionnaire, almost not necessarily just as a screen, but also a way of prompting discussion with the individual when we see them for the first time. But you will probably normally see that someone who doesn't kind of have a severe learning disability, then they'll probably almost kind of score probably above kind of 6. And the AQ is downloadable as well from the internet, and it's free to download. So you could actually, or the person you support, you could support them to go to their GP and say, look on the AQ, NICE guidelines say X, Y, and Z. Now, the tools that the NICE recommend are these following tools. It might be hard to see from the back. So you've got the AAA. I don't think that's enough. We use that in our screening. Because again, you need to be thinking about observational side of things and also developmental history to be able to then correspond. Because if you think we've not only got the NICE guidelines, we've also got the DSM-5 as well. And there's some incompatibilities there, but we always have to use the DSM-5 as clinicians. We can't deviate from that. There's the Autism Diagnostic Interview, which is the ADIR, and I'll go into that more. The Autism Diagnostic Observational Schedule, the ADOS. The Asperger's Syndrome and High Function Autism Diagnostic Interview, and obviously, of course, that's not necessarily a reliable tool now because of the changes. And also the Revito Autism Asperger Diagnostic Scale. The following tools are particularly useful for people with learning disability, also people with quite complex presentations as well if they've got mental health difficulties. So the ADOS and the ADIR, and that's the two that we use. So the ADOS 2 some of you might recognise this, but this is what the ADOS curve 2 looks like. Yeah. Now the ADOS 2 it's an observational schedule. So a clinician has to have training. It's a 5-day training that you have to go on to actually be able to use the ADOS reliably and clinically. So it consists of a series of tabletop exercises. So this is a particular almost test as well that it's not tasking, but there are particular activities that you will go through that will invoke certain responses that are compatible with an autism diagnosis. So there's certain things that we look out for. So it's an observational module. It's not actually what you're thinking about in terms of the task. So, you know, in how well you do on the task, it's actually what we observe. So things like eye contact, facial expressions, body language, how the person thinks about answering the question. Does that make sense? It'll be observational. And that will take place between the examiner and the individual and probably lasts up to about 60 minutes actually. But it assesses the 4 main areas that's in the DSM. So language and communication, reciprocal social interaction, imagination and creativity, and stereotypical kind of patterns and restricted interests as well. So we have to demonstrate that in the ADOS that people have difficulties in all of these areas, or observations in all of these areas. Now, at the Tuke Centre, we use the ADAR as well, because the DSM says that we have to have a clinical history. It's important that we have a developmental history. Now, we use the ADAR because, again, that's a particular assessment here. It's quite a lengthy booklet, but it has, again, the reason why we use the ADOS and the ADAR is because they're the tools with the most evidence base in terms of reliability for assessment. Now, and this goes right back to someone when they're really small, and we're asking someone's parent, caretaker, or someone, family member who's known them from such a young age to be able to report on their difficulties growing up. So it covers early developmental history, and we want to be able to see the person really to have known them from about 4 and 5. Because what we know from that age is the person is then starting to have more social demands that are placed on them. And especially those who find it easier or find ways of coping and masking at 4 and 5 years old, they may have not kind of developed those kind of coping mechanisms at that point. So that's why we think about that particular age. Now, what are the benefits of a diagnosis? That's what many people ask. They call up and say, well, I'm an adult. Well, what difference would this make to me if I had a diagnosis? Now, often, these are the things that people have to talk about. So it can actually be a great sense of relief for the person. That actually, finally, there's an explanation behind years and years and years of difficulty. Or even almost misdiagnoses as well. Lots of people on the spectrum will probably have a few different diagnoses under their belt. It also opens pathways of further support. So, for example, psychological support. Now, as a clinician, as a psychologist, I can work across the different presentations. But with autism, I work very differently with someone in psychological therapy than I would with someone with a different presentation. So again, it's really important for a clinician to know if someone's on the spectrum so they can gear their approach to the individual. Because again, it may be that therapy might not be able to be adapted to the person's needs if it's not uncovered. Because again, if there's some therapies that try to reduce someone's difficulties, when actually what we know is for many people on the spectrum, this is a lifelong disability. The people will often experience these difficulties for all their lifespan. All we can do is help to, with strategies, and help to alleviate often stress or crisis points as well. Under the Community Care Act 1990, and also under the Autism Act as well, it says that once you have a diagnosis, you're entitled to have a social care assessment. So whether you have a learning disability or whether you're very, very high functioning, because even I've worked with someone who was a lecturer and he was very, very high functioning, but he needed lots of support at home. So he had a PA. So he was entitled to have a PA to help him with his difficulties on a day-to-day basis. And also as well, someone may be entitled to welfare entitlement. So if you think of the kind of PIP payment as well. And again, the PIP payment is quite an interesting assessment tool in itself, and we often work with individuals to think about actually how they can phrase their difficulties within the set questions that are often given in the booklet, but it's a kind of knowing what to say. Because what we do find is often lots of people on the spectrum will find even accessibility things, even just going out, trains, buses, all of those things really, really difficult, but actually to get a taxi or to get, it's actually really expensive, all of those things. So there's lots of entitlement there, and we worked with one particular person who wanted to go to university, but there were so many different obstacles in his way to be able to get to university, but the PIP payment enabled him to be able to pay for a taxi or pay for a train ticket outside of the times that wasn't cheap, so he could actually get to university and enjoy his time there. And as many of you know, autism is now a registered disability under the Equality Act as well. So employers, educational establishments and services all have to make sure they're making reasonable adjustments. And that's right, you hear here, and often at Tuke Centre we have to always think about how are we making reasonable adjustments for this person. So for example, we're running a social skills group for people with autism, and to be able to help people learn the skills around social interaction, about the rules around social interaction, because this particular group that we're working with want to be able to socialise, want to be able to use social interaction in their way, to be able to meet their dreams and aspirations. Now, often in terms of our reasonable adjustment, we found that lots of people found knowing what to expect was really difficult. So we actually provided an accessible information sheet with photographs of the facilitators, photographs of the room. We even invited them in beforehand, so to talk through the structure, even introduce them to the room, introduce them to the things around them. So again, all trying to make reasonable adjustments around that person's needs, and there's lots of things you can do to support people on the spectrum to make day-to-day life easier. Now, when someone has a diagnosis, adjusting to a diagnosis can also be an emotional roller coaster. And it can be a really emotional time as well for family. So not just the individual, but whether they're their partner or their family, because everyone goes through that emotional roller coaster. Now, the individual may experience happiness, relief, frustration, sadness, anger, and all these feelings are understandable based on the diagnostic process. Because if you've not been diagnosed until you're, say, 60, now you're probably going to look back through your life and think, I'm really frustrated. Why wasn't it picked up? Angry because of that. Frustrated, let down. Or it could be now you've got a diagnosis and you know that these difficulties might be lifelong, that might actually feel quite sad. But then on the opposite side, it may be a great sense of relief. Finally, you can get the support you need. Finally, actually, maybe other people will understand. My family will understand. My relationship, my partner will understand. And we often give this particular transition curve to people who come through the diagnostic process. And you have to forgive us because I couldn't find one actually that was big enough that you might not be able to see, but I'll kind of talk you through it. If you think of when someone's coming in for the diagnosis, people can often go through a roller coaster of different emotions. So the first thing might be just complete denial, or just kind of not feeling anything, not feeling kind of any difference. And then it can be, no, that's not me. No, that doesn't make sense, that's not me. Can be anger, feeling quite low. Right down to, what's the point? But then as slowly as that person starts to accept their diagnosis, again, it can go up again. And if you see the kind of the cycle here, they're actually in a much better place long term for having a diagnosis, but they might have to go through emotional roller coaster in the first instance. So that's where post-diagnostic support is really important. So with all of our diagnostic assessments that we do at the Tuke Centre, any of our funded diagnostic assessments, we actually include a follow-up session within our diagnoses. Because again, it's really important that you don't just actually give someone their diagnosis and say, okay, here you go, goodbye. But we also ask commissioners to fund post-diagnostic support sessions as well. So as part of the diagnostic report, we will actually recommend further support depending on where that person's needs are at. So, because a diagnosis in itself can bring so many questions to mind, and with lots of different things that might come up. Parents as well, many questions to parents' mind. Is it my fault? Is it something I've done? All of these types of questions are normal with any diagnostic process. So the post-diagnostic support sessions really capture those questions, but also help that person transition through that emotional roller coaster in a way that's not going to affect their mental health as well. So strong post-diagnostic support has been shown to improve quality of life long term, reduce anxiety and depression long term, because finally the person's not blaming themselves anymore, not giving themselves a hard time, because actually something explains what they're going through. And also it decreases the use of high acute hospital services. So this is kind of statistics from the National Audit Service. So for those people who may always hit crisis point and always end up in A&E, always end up in inpatient mental health services, actually having a diagnosis can be really, really important. Now, there are some implications of a diagnosis you can see. Now, when we meet someone for the first time, we have to always ask these questions, because sometimes it's about timing with a diagnosis. It might not be the right time for someone. Be careful of elevating risk, because if someone has a lot of risk to keep themselves safe, then if they're going to have to go through that emotional roller coaster, then you're going to have to make sure they have a good, solid support network around them. But also it's important to manage expectations and limits of what a diagnosis can do, because it doesn't change anything in terms of their everyday functioning, but what it does, it can help them feel and think about things differently. They may still have the same difficulties, so again it's about managing expectations, because some people can come with that expectation, I'll get a diagnosis and that's it, everything's going to be great, everything's going to be fine. It will be better. And you know, we've worked with lots of people where having a diagnosis has opened up so many doors for them around psychological, emotional, welfare, social care support, reasonable adjustments in the workplace. Of course it's going to make a huge difference to their quality of life, but it's just managing that expectation. And also involving families and support networks in post-diagnostic support, because again, if that person then has to go back to their family and explain, and they might be still struggling to make sense of it themselves, then it might be hard for families to reflect on that. And also as well, families may have their own emotional or kind of interpretation of that. So it's to be able to catch those things as well, so the person is fully supported. Now, there's a little bit about patient feedback about after being given a diagnosis. So people have said that it's been such a relief. One person said that it saved his relationship. So it's a particular case that I talked about yesterday. He was a guy who was always getting in trouble with his wife, and actually it saved their relationship, because we ended up doing some work with them as a couple. So then they almost kind of, she understood him a little bit better, and kind of adapted how she could adapt her kind of self to their relationship, and also he understood why maybe his wife was getting quite upset as well. One particular person said, well, now I have a job I love, because this particular person was in a job and he was actually going to get the sack. And he worked, I won't name this particular company, but he worked for a particular company where now they've actually really embraced his diagnosis, and he's in now a separate part of the company where he's actually talking to other people about autism and supporting people through that process. And he absolutely loves his job, and he's actually doing really, really well. one person said that actually things finally make sense and actually it's not my fault, which is often a common cognition with depression. It's my fault. And someone who's coming on Thursday to speak, Ollie, and he will talk about this, but he said that it was his first step in his recovery. And he actually talked about this in the newspaper as well, that he'd been through mental health services for years and years, and inpatient stay after an inpatient stay, and he got his diagnosis when he was here on one of our units here, and finally things made sense. And he can then make sense of things and actually see his future very differently. So overall, our experiences at Tuke Centre are that having a diagnosis can be a really, really positive experience. So even someone as an adult, it can still really make a difference whether they're 18 or whether they're 70.